or behavioral change can be useful in your jobs?
You mean like specific instances?
Yeah, patient situations or scenarios or settings.
I think smoking cessation.
Great, yeah, smoking cessation.
Weight loss.
Weight loss, yep, yep.
Lifestyle change.
Yeah, any kind of lifestyle change. Great. So I'm going to start screen sharing again. Are you seeing what I want you to see? Maybe? Good. Okay. So this, a lot of this is borrowed from a previously published workshop, and then some from a training I went to back when I was a third year resident, about to start my chief year. There's a program for rising chief residents to learn like teaching around substance use disorders. And it's really fun, and it's on Cape Cod, and you get to spend 3 days on Cape Cod talking about substance use disorders and counseling and things like that. So some of the skills that I learned at that workshop are also reflected here. Maybe. So we're going to do sort of an intro to motivational interviewing, a refresher, and then the most of the time is going to be dedicated to skill building practice like last time. So what is motivational interviewing? It is a directive counseling style that helps facilitate the intrinsic motivation of your patient to help them change their behavior. And the center of all motivational interviewing is around sort of naming and resolving ambivalence, and then helping really describe discrepancies between a patient's current status and the way they want to be. So really leaning deeply into, like, you are here, you want to be here, what is in that space in between. And your role is to be a catalyst, to be curious and non-judgmental, and to identify the problems that they're having and help them establish their goals. It is a really non-prescriptive space, which I think can feel weird for doctors, where we want to sort of be asked what to do about a problem and tell people what to do about a problem and then move on. And motivational interviewing is really not about that. So the general approach, as I mentioned, this is a collaboration and a partnership. If you ever feel like you're trying to do motivational interviewing and the interaction is becoming confrontational, then it's no longer motivational interviewing, because you're always on the same side as your patient. You want to draw out their ideas. So it's always about eliciting their ideas, their change talk, their internal strengths, their barriers, not sort of prescribing what you think is going on with them. It's all about autonomy. As any of you know, anyone who's ever trying to change a behavior, which is actually extremely hard, if it weren't hard, we would all be, perfect in every way. It's all about autonomy and self-efficacy. So this is not, most of the issues that we're going to be dealing with motivational interviewing are not things that can be solved by someone else. And again, resist the urge to jump to problem solving. I'm sure we can all think of situations where you could list a dozen things that someone could and should try to help fix the problem, but if that's not their idea or their plan, it's not going to work. Oh, sorry, I didn't change the names here, but what we're going to do in alphabetical order by your first name. So I actually don't know who's the first. Is it Andy? Yes. So you're going to have to be very thoughtful about this because it requires alphabetizing. And I know it's been a long time since first grade for you guys. So in alphabetical order, starting with Andy, I want you to say 1 to 2 sentences about your weekend, this past weekend. And then the next person in the alphabet, sorry, I have to keep scrolling back and forth between. Would that be Erica? Am I missing anyone? Alex. Oh, sorry, Alex. So it'll be Alex and then Andy. Okay, so first is Alex and then Andy. So Alex tells us 1 to 2 sentences about his weekend. Andy is going to then make a reflective statement about what Alex said using one of the following, either simple, paraphrasing, amplifying, or double-sided. So for example, if Alex said, one thing you should know about me is I'm addicted to coffee and drank 2 pots a day this weekend, Andy could say, you're addicted to coffee. Or you need lots of coffee every day. Or you would die without coffee. Or on the one hand, you drink coffee every day, and on the other hand, you seem to think of this as a problem. And then when you're done reflecting, doing one of those techniques, it's your turn to tell us about your weekend. And then the next person in the alphabet will reflect on you and then go ahead. Does that make sense? One thing to keep in mind is that these aren't questions, they're statements. So when you're doing reflective listening, try to avoid up talking where you sort of swing the tone of your voice up at the end of a sentence, because that makes the person listening feel like you're asking them a question when in fact you're just trying to reflect on what you just heard. So Alex, take it away. You're muted, my friend. I'm gonna get a t-shirt. It's gonna say, you're muted, my friend.
Something about my weekend specifically?
Sure.
Okay.
It could be real or fake, I don't care.
This weekend, I am going to go apple picking because I love being in the outdoors, and having that resource is something I don't want to waste.
You love to take advantage of the outdoors.
Awesome. Now, Andy, tell us something about you.
This weekend, I'm going to clean my apartment since I don't feel comfortable going outdoors.
Erica, I think you're next in the
Right.
alphabet.
I thought we were going back and forth between those two. Gotcha.
No, we're going to keep going, progressing through the alphabet.
You feel safe in your apartment. This weekend, I plan to do a lot of food prep.
Oh, am I next?
I believe so.
You like to be efficient on your weekend. This weekend, I'm also gonna stay inside because of the smoke.
Is it me or? Yeah. You're concerned about the air quality outside. This weekend, I am going to go visit my wife in Spokane because I love her very much.
You're going to get the chance to spend time with somebody you care about this weekend. This weekend, I am going to try to go kayaking outside.
Jordan, this weekend you're going to go kayaking, or at least try to. This weekend we're going to have a board game night Saturday night because we like to play board games.
Since you like to play board games, you're going to have a board game night this weekend. This weekend, I'm going to the Washington Coast and seeing my family.
You prioritize spending time with your family. This weekend, I don't know what I'm going to do because my campsite just got canceled on me during this exercise.
You're unsure what you're doing this weekend. This weekend, I am probably going to be doing my laundry because it's been a while.
What I'm hearing for you, Marina, is that you are having difficulty keeping track of your hygiene right now. Just kidding. Just kidding. Just kidding.
That was a good amplification, Nick.
Just trying to make assumptions here. This weekend, I will be watching the Seahawks game because I'm a sucker for sports.
It looks like Nick loves football. This weekend, I'm going to try to go hiking because I've been doing a really bad job being active.
Seifu is going to go outdoors this weekend. This weekend, I am going to be indoors.
All right, Alex, I think we're back to the beginning, so you get to reflect on Tam's statement.
Sorry, I was typing. Tam, would you be able to repeat what you said? I heard this weekend.
This weekend, I'm going to be indoors.
Tam, it sounds like this weekend you're going to be indoors.
All right, thanks everybody. I know it's a little silly, but reflective statements actually make people feel really good. Your patients feel heard. They think you're taking good care of them. Even if you don't know exactly what to do or how to help someone, reflecting their own feelings back to them is a really powerful tool. One thing I noticed that I think is really effective is when people used each other's names. It felt really personal. So I think that's a nice thing to think about, is to say, Marina, it really sounds to me like you're having a hard time keeping on top of your chores, which is so normal for people who are interns. So I'm sure there are a lot of people in the same boat, right? Great. So classic principles, there's a lot of different mnemonics, and I don't know if you all are mnemonics people or not, but I'll share some of them that have been widely publicized. ORS is one, which stands for open-ended questions, affirming your patient's perspective, reflecting back to them what you're hearing, and then summarizing. So you want to be coming into this encounter with curiosity, with empathy, and with sort of support of their self-efficacy. The acronym that I learned was DARES, which is develop discrepancy, avoid arguing, roll with resistance, express empathy, and support self-efficacy. So often when I'm talking to someone about behavior change, whether it's around smoking or alcohol use or other substance use disorder, whether it's about lifestyle changes or medication adherence or anything, my personal mascot maybe is those like wobbly blow up dolls outside of car dealerships, you know, when they're like having their Labor Day sale or whatever, and there's like air blowing into those like wobbly things and like the wind kind of blows them around. I think of that as a patient is moving forward, I'm going with them, and as they're moving backwards, I'm going with them. So I'm never moving in the opposite direction of a patient. I'm never trying to create tension there. There are times when I'm going to disagree with a patient, and I will tell them I disagree with them, but motivational interviewing isn't that time, because what they're telling you is their reality. So you can't try to like tell them that their reality isn't their reality. Another tool is the readiness ruler, which oftentimes feels really weird to use at first, especially if you've never done it before, but actually in practice, I think can be a really helpful thing to use. So the readiness ruler is getting people to rate on a scale of 1 to 10 how important it is for them to change and how confident they are that they can do it. So those are sort of the fundamental pieces within motivation. So this is something that's important to me, and I am confident that I can do it. So you ask people on a scale of 1 to 10, how important is it for you to wash your socks this weekend? And on a scale of 1 to 10, how confident are you that you're going to be able to do it? And in order to get change talk, which is the kind of talk we want to get out of our patients, you ask them, oh, wow, it's a 5. Why isn't it a 3? And how do we get you to a 7? Instead of, why isn't it a 7? Right? Because if you say, why isn't it a 3? It gives you all the reasons that it's important. And then how do we get you to a 7 is getting them to talk about all the self-efficacy and intrinsic skills that they have. Does that make sense to everybody? You say, why not lower, and how do we get you higher? And then the concept of dialectics is that two things can be true and in opposition at the same time. And this is sort of a foundational piece of like dialectic behavioral therapy for people with personality disorders and things like that. Like you can hold two truths in your hand at the same time that oppose each other. So on the one hand and on the other hand, that's a really important statement to be able to make to people when they're trying to change. On the one hand, you really want to lose weight because your knees hurt. And on the other hand, you eat when you're stressed out and sad. And this has been a really sad and stressful time for you. Those things are both true, right? Even though they're in opposition. It sounds like smoking is a huge stress reliever for you, and you are really worried about the effect it's having on your health. So try to make sure you can find those areas of discrepancy to kind of pull out those dialectics. And this is my like importance and confidence 2x2, that I try to put my patients into one of these quadrants when I'm talking with them, sort of mentally in my brain, to help think about what's the next step for them. So you think about confidence and you think about importance. If someone has high confidence and high importance, they're willing and able. Now is a really great time to support self-efficacy and set some very concrete goals with them. If something is extremely important to them, like I have to quit smoking. I've been hospitalized 8 times this year with COPD and I'm going to die, but I have tried to quit 27 times and I've never been able to go more than 5 hours without a cigarette. That is somebody for whom this is highly important, but they have low confidence and obviously need a lot of external resources and help to support them. So you can think about where people are. If someone is in the lower right quadrant, the unwilling and unable, that's where you just make a strong recommendation to them and move on, right? Someone says like, yeah, I know I should, people tell me I should quit smoking. I love everything about smoking and I have no desire to quit smoking. Then you counsel them. I think quitting smoking would be one of the best things you could do to improve your health and well-being. And we can talk about it later. And so sort of mentally put your patients in one of those quadrants. Some common pitfalls in motivational interviewing. Not having enough time. It can take a lot of time, actually. I would say if you're not able to dedicate a good 10 minutes of your visit to motivational interviewing, you're probably not going to get very far. Or curiosity about your interviewee or patient's perspective and context. Patients' contexts are so central to their care, and if you're not curious about where they're coming from, it's going to be really hard to help them. Coming to them from a place of judgment, the righting reflex, right? We all want to fix problems. We are problem solvers. We are, people who take decisive action and fix things, and the desire to make things right for somebody else is goes kind of counter to motivational interviewing. So you have to sort of bite your tongue and not try to say, well, here's what you should do. Let me tell you how you're going to fix this problem. And then coming up with a non-specific plan. So if someone is wanting to quit smoking and you say, great, sounds like you're super motivated. This is really important for you. This is really confident. Let's talk again in 3 months and see how you did, right? So you need to make sure that there's an actual plan for the patient of steps that they're going to take and steps that you're going to take to make sure that things are going well. So here's sort of the anatomy of a brief MI or an MI or brief intervention. Obviously, you want to build rapport with the patient. You want to get pros and cons of their current behavior. And don't forget to ask them what they like about it, right? Because it's really hard to help someone change if you don't know why they're doing what they're doing. So I always ask people, like, what do you like most about smoking? Oftentimes it's stuff you would expect. Sometimes people say, I don't like anything about it, actually, I just can't stop. And that's also a really important bit of information to know. You want to do some reflective listening, do some of those dialectic statements, make a recommendation, give the advice, assess their readiness, and then talk about an action plan. Any questions about any of that so far? Okay. So the next thing we're going to do is actually get into groups of 3 or 4. Actually, let's get in groups of 2. So we don't need an observer. So we're going to get in groups of 2. And you will each have a chance to be the patient and you'll each have a chance to be a provider. You're going to start with the phrase, one thing you should know about me is, you can say whatever you want. You could say, I'm addicted to Izelle's famous fried chicken. You could say, I'm really into wearing dirty socks. You could say whatever you want to say. If you want to talk about, if you want to practice something more actually serious, you can say, I can't stop smoking, or I'm drinking too much, or I have a substance use disorder, or whatever. Or you can talk about whatever you want. And you want to do like 5-ish minutes, 5 to 10 minutes for the interview and intervention. So doing an actual motivational interviewing session, and then 3 minutes for reflection and feedback on how it went, and then switch. Does that make sense to everybody? So the slides for this are all in Microsoft Teams also. So if you want to pull up the slides through your Microsoft Teams, you can see some of these tips and tricks and best practices. If you also just want to go for it and see how you do, that's also fine. Try to use the readiness ruler, try to do some reflective statements, try to find discrepancy and create some more of those like dialectic statements on the one hand and on the other hand, and see how that goes for you. So we'll break out again into pairs. We will come back in, I was going to say about 20 minutes to reflect on how things went for you. And then we'll have another 10-minute break at that point. Okay? Questions? If you have any problems, please leave your breakout room, because Whitney and I are here to help you. And then we can put you back into your breakout rooms. Thank you for your presumed participation. Wanted to do some reflection on how that went for everybody. So some general questions, kind of, how did that go? What did you learn? What was easy? What was hard?
So Nick made a really good point about, as much as I think we want to try to like fix things, it's more powerful if the patient kind of comes to that realization themselves. And so it's, try not to kind of cut them off or like kind of make that leap for them. You just sort of have to kind of guide them towards that conclusion. And if they don't get there, that's okay. You'll kind of have that discussion again. But again, it's way more important, way more powerful if they kind of make that decision, that conclusion themselves.
Awesome. Such a good insight and so true. And I think we all know that. We know that for ourselves. If you have somebody tell you to do something versus you wanting to do it, like which one is more likely to happen? And that is true of all humans, and also true of our patients who happen to be humans with the same personalities and quirks and foibles that we all have. What else did you see that worked really well?
I was the patient and Lauren was the physician, and I was telling her a real problem that I had, and she really did a good job asking me questions and open-ended questions that made me talk about my problem. And then when I was talking about the problems, she was making me realize that, oh, I'm doing this because of that, I could do this. So I was the one kind of coming with these solutions, at least in the back of my mind when I was talking to her. And I think that was really good in a way. She was not giving like hard recommendations necessarily. She would be like, oh, it looks like you're doing this because of this, but you want to do this. I think that was really good. And Kim was the observer, and she added, I think she added a good point about also making some recommendations and like kind of summarizing it.
Awesome. So it sounds like Lauren did a really exemplary job of supporting your self-efficacy and drawing change talk out of you, which are really core skills in motivational interviewing. So getting your reasons and your motivation drawn out and your strengths and your resources, right? These are all the things that we need to discover about our patients that we're trying to help. So good job, Lauren, and thanks, Saifu, for recognizing those things that were happening. What else did you see that worked well?
So pulling up and looking at the slide that you made, the anatomy of an MI/brief intervention, one thing that Erica did really well is that, it's really easy sometimes to follow down things systematically, which can seem very robotic. She was able to kind of weave all those points into a conversation that felt very natural. So I thought that was really awesome. There are times where you had open-ended questions, but then also closed-ended questions, and then allowing for reflection. And I'd never role played this with somebody doing those simple reflections before. And I think she mentioned, she was like, God, it didn't feel right. But to me, it actually felt like she was actively listening. And so it, from my perspective, I was like, wow, you actually were doing a really good job.
Mm-hmm. It feels good, doesn't it? Even in these phony kind of skill building sessions, it feels good to be heard. So just remember that your patients will feel really good in your visits if you hear them, even if you don't solve anything. And one thing I remember watching one of our current R3s a lot when she was an intern, and she just had the most incredible patient affect kind of relationship building skills, and was so insecure about her medical knowledge, which was also totally fine. But every visit, she's like, I didn't do anything for that person. I'm like, what are you talking about? That person felt heard and valued and honored, probably for the first time in a long time. And that you can't discount the importance of just that as a therapy. Cool. Anything that was hard or that you tried and felt like, well, that didn't work for me, or that felt phony or artificial or weird or anything like that?
I think there are a couple opportunities where during these hard conversations that I had missed opportunities to make the patient feel good about themselves. So Eric was talking about someone who was having a drinking problem, and they hadn't had a drink in 3 weeks, and then kind of paused and went on. And I felt like it was a missed opportunity to be like, wow, that's great. You haven't had a beverage in 3 weeks. Really, you should be proud of that. So there are some times where I felt there were some missed opportunities to like congratulate the patient.
Yeah. Good, right. Highlighting people's successes and their self-efficacy and their strengths, acknowledging when people do things that are, when people successfully do things that are hard. I think it's a great opportunity to help support self-efficacy. Awesome. So do you all think that you have a chance to practice this in the next 3 days of clinic? I'd encourage you to do it, and you don't have to do everything, right? You don't have to do a full-on, this is going to be a 30-minute motivational interviewing encounter, but try to elicit some change talk. Try to use the readiness ruler. Try to just think, today I am going to focus on reflective listening. I am going to intentionally practice reflective listening with every patient I talk to. You know, you can do things like that to work on your skill building. And it feels good, and you'll find at the end of the day, I feel better about the care I provided because I actually was really present in the moment with my patients, and that feels good. And the rest of the world can disappear for a minute, and that's a nice space to get into. Awesome. So you do also get to have observations of counseling on behavior change. It's 2 observations, and again, it doesn't have to be a huge thing. It can be you know, doing a brief motivational counseling on medication adherence. It can be smoking cessation counseling. It can be, you know, a brief intervention around alcohol use. So find a couple opportunities. It can be around sexual behaviors. It can be about whatever your patient needs. And so make sure you get observed. Again, it can be an attending. It can be a primary care R3 or a chief. Make sure you log it into MedHub.
Can I ask you a quick question about the observations?
Yeah.
Do we say, I don't know, say somebody's come in for some other problem, they bring up their use during when you're initially seeing them. Do we then pause, go grab an attending and say, will you come watch me do an interview? I just don't know the timing of when we're supposed to request these.
Yeah, one way to do it is to not do that part of the intervention until you're staffing. So say I'm staffing this patient who's actually here for diabetes. I'm hoping you can come in and watch me do a brief intervention about alcohol or about weight management or whatever else. If you have instant messenger, Skype, often I will tell people when I'm attending, I'll be on Skype me if you want me to come into the room for any reason, or you can come get me. So if it's not awkward, you can always send a secure instant message to the attending if that's a system that you use in your clinic. But I would usually say, if you do identify ahead of time, and it's easier with the other skills, right? Agenda setting, obviously you're going to do that every visit. Taking a history, you're going to do that every visit. But for things like prescribing a medication or counseling on behavior change or counseling on screening and prevention, which we'll talk about next, those you have to kind of do more in real time. Yeah. So I'd say do the rest of the visit, go staff, grab the attending, say, hey, can I have you watch for 5 minutes while I do this last part of the visit? Other questions? All right. So let's, if you don't